How's it going, guys? Past level question of hepatobiliary, step 1 internal medicine surgery 2CK. 24-year-old man, 1 day history, severe right upper quadrant pain, temperature 102 Fahrenheit, hematologic disorder that was recently diagnosed with osmotic fragility test and eosin-5 maleimide flow cytometry. Hemoglobin low, 10 grams per deciliter, should be 13 to 17.5 in males, non-menstruating women, 12 to 17.5 menstruating women. He's scheduled to undergo a splenectomy and a cholecystectomy. Ultrasound of the abdomen is equivocal. HIDA scan is performed, shows non-visualization of the gallbladder. I'll explain all this as we move through the question, don't worry. And then we've got a normal HIDA scan from a separate patient shown. Question wants to know the most likely etiology of the patient's fever. Let's just hop through choice A. Clearance of RBCs by the red pulp, correct answer. So diagnosis is going to be hereditary serous-cytosis, autosomal dominant, heterozygous mutation, anchorin, spectrin, van proteins, which are RBC cytoskeletal/cell membrane proteins. And the RBCs are going to be normocytic, normochromic, that type of anemia. NBME wants you to know that. So they have micro, macro, hypo, hyper, chromic, all the different combinations. It's normocytic, normochromic. And they also want you to know it's autosomal dominant. Because it's autosomal dominant, which is high yield in and of itself, it's heterozygous, not homozygous mutation. So splenectomy, cholecystectomy, very buzzy combo done for these patients. You've got abnormal RBCs, so the spleen will identify those, the red pulp will identify those as abnormal and increase clearance. So you have increased production of bilirubin. That can be an answer on the NBME. It could just be increased liberation of bilirubin, increased production of unconjugated bilirubin, increased RBC turnover. These are all very buzzy answers for both hereditary serous-cytosis as well as sickle cell. Okay, now splenectomy, don't get confused now. Autosplenectomy can occur in sickle cell due to repeated microinfarcts, but we don't treat sickle cell with splenectomy. We treat hereditary serous-cytosis with surgical splenectomy because the constant/incessant RBC turnover can lead to pigment stone, calcium bilirubinate, cholelithiasis, okay, which if you get an obstruction of the outlet of the gallbladder/cystic duct, you get cholecystitis. So this is why splenectomy is a definitive treatment for hereditary serous-cytosis, and often in combination with cholecystectomy to relieve a patient's acute cholecystitis. Now, the HIDA scan is when you're attempting to diagnose cholecystitis, you're going to do an ultrasound first, which will be negative or equivocal. Normally, we'll see stones in the gallbladder for cholecystitis, but if it's negative or equivocal, we're going to do a HIDA scan. It's a radio tracer that's taken up by the liver. It's secreted into bile. The gallbladder should light up. If it doesn't light up, we know that that's because we have an obstruction of the outlet of the gallbladder, and we say, okay, that's cholecystitis. You need to know that for 2CK. So let's just hop through the other answer choices here. Choice B, common bile duct obstruction, wrong fucking answer. This would be choledocholithiasis or head of pancreas adenocarcinoma. Exceedingly high yield. Could do a lengthy discussion every point here, but they can give you a heavy smoker. Let's say there's weight loss and patient has high direct bilirubin, they're jaundiced, and they have a painless, palpable gallbladder, and they're afebrile. That's Courvoisier's sign for head of pancreas adenocarcinoma impinging on the common bile duct. The patient might not have a gallbladder, so a remote history of cholecystectomy, but they have obstructive findings where they have high direct bilirubin, high ALP, and you say, well, can't be a stone, it's got to be a head of pancreas cancer. So especially for 2CK, you got to know these differentials for hepatobiliary conditions. Wrong fucking answer. Choice C, hepatopancreatic ampulla obstruction, wrong fucking answer. So this is where you have choledocholithiasis, stone in the biliary tree that's descended distally enough where it's now causing pancreatitis. Okay, so not only would you have a high direct bilirubin, high ALP, same as with choledocholithiasis where the stone is higher up, but in addition, we have elevated amylase and or lipase. With head of pancreas adenocarcinoma, the pancreatic enzymes will not be elevated. And they want ultrasound followed by CT for the diagnosis of pancreatitis. Choice C, wrong fucking answer. Choice D, decreased secretion of cholesterol in the bile, wrong fucking answer. So this would mean we have a lesser propensity for stones, so it's probably the worst answer here. But the reason I wrote it is because this exact answer is actually correct if they're asking for the mechanism of action of ursodeoxycholic acid, ursodiol. Okay, so that's a drug that can be used for mitigation of stones in some patients, i.e. those who can't undergo surgery, or it can be used in conditions such as primary biliary cirrhosis, woman 20s to 50s, high cholesterol, high direct bilirubin, ALP, and she's got generalized pruritus and history of autoimmune disease in her or a family member. Choice D, wrong fucking answer. Choice C, increased hepatic production, bilirubin, wrong fucking answer. So some students will get a little bit flummoxed here. They'll say, wait a second, well, if you've got increased RBC turnover, you're going to have increased production of bilirubin, and that's ultimately going to be conjugated by the liver, and it's going to be secreted into bile. Yeah, but it's not the liver that's producing bilirubin. Liver is just conjugating bilirubin. And when you have choice A as the obvious, buzzy, easy answer here, that's unequivocally correct, you can look at choice C and say, yeah, that's not as good of an answer choice. Wrong fucking answer. You know the deal. I'm to make more content, like my subscribe channel. Appreciate your time. That's it.